Thank you, Madam Chair. All right. I'd just like to start by saying that I'm, of course, extremely sensitive to the suffering, terminally ill, and those who are considering physician-assisted suicide. And I say physician-assisted suicide because we have medical aid in dying already in medicine. It's called palliative care. It's called hospice care. In fact, I would like to make it clear that the Illinois Physicians, the Illinois State Medical Society, which I'm a member, is opposed to physician-assisted suicide. And it reaffirmed its opposition last month, their strong opposition to physician-assisted suicide. Additionally, they refused to call it medical aid in dying. That is a manipulation of the language. This is physician-assisted suicide, and they will only refer to it as physician-assisted suicide, and they will be opposed, as well as the American Medical Association has remained opposed. So I just want to make that clear, that the unified voice of Illinois physicians, despite any polls that we saw, is opposed. Physicians in Illinois, of which I am one, is opposed to physician-assisted suicide. And why are we opposed? Well, there's so many reasons, and I want to amplify some of the ones we went through today. But especially, I want to bring up the idea of coercion, and that is a huge ethical topic. And to hear that there is no coercion, where all we see is every state and every country, it's been tried, it expands, and the fears of coercion are realized, and we hear story after story, and what we have is stories. So I'd just like to talk about that somewhat. And Mr. Knowles, could you kind of expand on how disability groups, and do you have any data that would support your contention that disability groups feel like there is coercion whenever this is tried in any state or country?
So I would point to the 2019 report by the National Council on Disability, where they fully laid out multiple instances of coercion. There was an instance in California where there is a 85-year-old woman with dementia that her primary care physician and her managed care provider had decided that they would not authorize physician-assisted suicide because they felt that she did not have the mental capacity. Her family assisted her in doctor shopping throughout this process, until inevitably they found a physician and then a psychiatrist that agreed that she was competent, and outlined that, there may be coercive practices by her family, especially her daughter, that really seek to have this sought out. So I would, again, I would urge all members of this committee and members of the General Assembly to read that very in-depth report.
And in fact, it's not just physicians, it's also the insurance companies. And we contend with this every day, whether it be pre-authorization abuse, denials of care, underpayment, inadequate networks, on and on. There are different tactics that they use. This is the golden tactic. The cheapest care in this country is no care. And so we are partnering with insurance companies to give them the cheapest option for patients. In my mind, that's a huge part of the coercion that disability groups and other groups, even, what's the option for someone who has extremely rare cancer with extremely expensive treatment? What is their option going to be when their insurance company says, well, you have a terminal diagnosis? The cheapest care for you would be, you should consider suicide. Dr. Salvador, are you still? Oh, Dr. Salvador, can you just kind of just go through the science of the medical science of getting a prognosis, and how, what's the scientific evidence that physicians are any good at giving a correct terminal diagnosis or a time frame? And then also, if you could expand again on the comorbidities that patients often have with mental health issues and depression, as well as a terminal issue, terminal diagnosis.
Yes, thank you. Thank you for asking the question. So the first question is about, you said, second one was about comorbidities, and the first one is about prognostication. And unfortunately, there is no exact science when it comes to prognostication. We can do a professional assessment and evaluation, believing that an individual may have less than 6 months to live and that needs 2 physicians. But as we've learned from multiple cases, sometimes there are cases where we believe there's longer than 6 months and the person dies the next day from natural causes. There's also the opposite of this. And so we might say that an individual has very little time, and yet they are living for a couple of years. And cases have already shown, stories have already shown that individuals would say, you know, my physician thought I was a goner. And we made plans and we did a living will, and I'm still here after a couple of years. And the sadness about that is that how many individuals have been missed in terms of misdiagnosed in terms of this, or prognostication. Now these individuals are saying that they've flourished, they have spent time with their family, and they look back and say, had I had listened, my life would have ended at that time. So prognostication is unfortunately not an exact science. The other thing is about terminology, which I will say is that this is not medical aid in dying. This is medical aid in death. And palliative care is the best service to give to patients when they feel isolated, alone, lonely, fearful, vulnerable, and in pain. What we need is to increase services to help them with that in a compassionate and humane way. That is the way we treat one another in terms of being in a society that is humane and compassionate with one another. Concerning comorbidities, individuals who go through, most individuals who go through a very serious diagnosis, like a life-limiting diagnosis, will naturally feel anxiety, fear, and depression. Safeguards that are so-called safeguards that are out there, unfortunately fall through the cracks, and the human condition is one where abuse will simply occur. One particular individual said that we are not Canada and we're not US, but we are human. All of us are human, which means that when certain things are in place and society accepts a particular type of action, like assisted suicide, it will turn into active euthanasia. We need to learn from our own individuals, human beings, where this has occurred. This is occurring now in Europe and now in Canada.
Okay. Did you want to respond?
Just one point in terms of the diagnosis, the language around what's considered terminal and the process for a doctor to assess whether or not someone is terminal was made in collaboration with ISMS. We drafted language, we went to them to get their sense of what should be in a law. They explained to me in great detail their process of trusting doctors to make these decisions. They're decisions they have to make every day, especially when dealing with people who are terminal. So just wanted to share it. That's where some of that language and those frameworks came from.
Also, my understanding of ISMS is that it is a divided house. They had one position, now they have a new position. But also, I mean, we should all recognize that ISMS in general represents very few doctors in Illinois. And I don't know the exact number, but most doctors in Illinois are not part of ISMS, so.
Well, I just have to say that there are differences of opinion inside ISMS, but ISMS is united in its opposition to physician-assisted suicide, and overwhelmingly voted both last year and this year when brought the bill, overwhelmingly voted to oppose it. So there is definitely differences of opinion. I think that was pointed out. One more question I would have for the physician.
Okay, for which physician?
The Dr. Salvador.
Salvador, if you could respond.
So I have one more question. Since you're a medical doctor, isn't it correct that the cocktail that is used is extremely high doses, and we're talking hundreds of pills are dispensed, and often causes a lot of vomiting and cause lots of nausea. In addition, the time it takes for a patient to die is unknown. It can take hours and hours. So we're talking about a very dangerous cocktail of drugs, hundreds of pills that are going to be self-administered with no help from someone else. There's no medical person available. And if those drugs aren't used, we have extremely dangerous, hundreds of dangerous pills that they're supposed to dispose of, but we all know how that goes. So we possibly could have a situation where there's hundreds of dangerous pills in a person's house, and there's no medical control when they actually do ingest, if they're able to ingest. Is that accurate?
Yes, it is, absolutely. I agree with everything that you just said. I'll also comment on the fact that when a person is going through the active dying phase, their body is already going through organ failure. This is not just heart failure or pulmonary or lung failure. This is also gastrointestinal failure. So that means there could be partial treatment from a lethal standard of drugs. And so because the dosage is so extremely high, that does not guarantee that the goal being death is what is going to happen. So that individual can actually suffer and just not speak and be able to tell anybody around them what they're experiencing. Yes, their respirations may slow down, and yes, death is the eventual goal. But in gastrointestinal failure, which is why we do not feed patients in hospice when they cannot eat, we don't force this upon them. Unfortunately, just because the patient cannot talk does not mean they're not suffering.
Okay, I'm a
just
little
wrap.
confused about the process because I don't know much about it, but I know you described it differently and Ms. Flack described it differently. I wonder, is someone that actually has
Can Dr.
practice in this
Barnard
area?
reply to that?
I mean, are there
Respond to
hundreds of
that.
pills? I don't remember hearing that when you described it.
Dr. Barnard has experience with this. If you could let her respond as well.
Dr. Barnard, can you respond to that piece?
Thank you. So first of all, I would say that all of the medications that are used for medical aid in dying are FDA approved. They are used in a combination that is not FDA approved, and that is actually much more common in medicine than perhaps people realize. And these are not pills. These are compounded forms of the actual medication that are put together in a small amount of a powdered formula, which the individual, if they choose to go forward, would mix with a small amount of liquid and consume about 2 or 3 ounces. And these medications, like all medications that are involved in a typical palliative care or hospice patient, can be lethal when in the wrong hands. And so most people are on hospice. This day and age, we have all sorts of ways for people to dispose of medications that are not used. And this bill in particular has language regarding the importance of keeping track of the medication. And I also just want to emphasize that the data that we have shows that the vast majority of people go to sleep within 5 minutes. More than 80% of people have died within 2 hours, more than 90% within 5 hours. There may be some variability in how long it takes the body to shut down, but this is a very reliable practice. Any medical procedure can have the possibility of complications, but they are not common in this carefully crafted protocol.
Okay. Dr. Hauter, do you have
I just have a closing statement. This is ultimately the practice of medicine. We're talking about the practice of medicine. You're asking physicians to be complicit, at least complicit, even if we do not actually involve ourselves in the prescribing of the suicide medications. But there are so many issues I have with this. I wish we had a lot more time. Obviously, again, Illinois State Medical Society and the AMA is opposed to physician-assisted suicide. This is incompatible, and I heard the words incompatible. This is incompatible with the principles and the actual purpose of what I went to medical school for, and many physicians have taken an oath, a sacred and ancient oath to first do no harm. I would hope that this committee would think very, very deeply about this issue. Thank you.